All right. So let's spend, I guess I am keeping us from the bar, supposedly, so we'll go ahead and get started with that. Even though my chair knows who I am. I'm Craig Cooley. I'm the EMS Fellowship Program Director down the road at San Antonio and one of the Deputy EMS Medical Directors. So I don't have any financial disclosures, but I do have shame because I actually come from a system that actually has diversion, and I'm trying to change it, and maybe someday I'll succeed. But when we want to talk about this concept, we want to really start, and we want to start at the beginning. And so if we flash back to the 1980s, emergency medicine was in a crisis. We had waiting rooms filled with people. We had exceedingly long wait times and dangerous wait times, and it was all due to us boarding upstairs patients that just couldn't find a place to go. I don't know if this sounds familiar to anyone, but times have not changed that much in some ways. The other key to this that kind of without real evidence started down this idea, this dogma idea, was that this was all being driven by patients who didn't need to be in the ER with minor complaints or social issues or those kind of things. Sure, we still have some of that today, but any ER worth its size also has a fast track to deal with these patients because, let's be honest, they're relatively easy patients to disposition and they're financially rewarding if you can set up your model correctly. But along this same line came this idea that if we can stop the patients from coming, we'll use diversion of EMS traffic to do that. And so with the concept of like the ER is getting crushed with patients, we just need a little bit of time to reset and everything will be better and all our overcrowding problems will go away. It reminds me of The Princess Bride with the famous line, "You keep using that word, but I do not think it means what you think it means." So when I talk about diversion, I want to be very specific that we're talking about hospital-initiated diversion because of volume. There are reasons that a hospital ER should go on diversion, and we'll touch on those in a little bit. But because of this idea and this dogma, all these myths develop over time. And the first and the big one is this idea that it's an ER problem from the overcrowding problem. I think we all know that's not the case. There's three things that drive our volume, and we have long since solved throughput. We're still moving deck chairs from time to time. Our department recently, did a change with some fast track stuff and changed our hours and made some difference. But reality is, if we can't get the patients upstairs, we can't get the patients transferred out by EMS, which of course is backed up because of diversion, or and to some extent discharges, then that's what's really causing our problems. But we spend a lot of time focusing on this small piece of our arrival pie, which is EMS. Most ERs only see 20 to 25% of their patients being EMS traffic. And so why are we spending all that energy on that one little part? And it's not just me. When you look at ACEP, they look at this from the standpoint of the output problem. And I love the line they have here that hospitals should not seek or expect relief for inpatient movement inefficiencies for the EMS patients. So they look at it from the output side. As you would expect, NAMSP sort of looks at it from the input side of the EMS traffic themselves, saying that systems should limit the time ambulances are out of service because of diversion or offload delay. And just to be clear, wall time or offload delay and diversion are two sides of the same coin. So I would make people kind of focus on this idea of input throughput. We complain that our problem is our output, it's not us. We're EMS's output. And so us causing them problems doesn't seem to help them be available for the patients that they need to go respond to, which could be our family members. The other big myth, the next one, and this is really the foundation of the whole thing, the house of cards, is that when we're on diversion, then the patients won't come to us. And the first things we have to understand is it's a request, it's not a command. EMTALA is still in place, they're still going to bring patients, we can divert override if we want to. And then the hospital has to be honest. You got to divert everything. You don't get to pick and choose and just divert your psych patients or your general medical patients and keep all your shiny patients. If you're really in crisis mode, you should be closing the doors to absolutely every patient coming through the door. But you're still going to get your cardiac arrest. You're still going to get your critical overrides that come in because of airway failures or something. And oh, by the way, all those accrediting bodies of STEMIs and strokes and traumas frown pretty heavily if you go on diversion of their kind of patients. So it's going to be hard for you to do that as well. And those are potentially pretty complicated patients. By the way, the front door still stays open, so we don't get to close the front door. And I've always asked, I like to ask this question, what would you rather have as an ER doc? The patient that's been treated, evaluated, vital signs, determined stability, and probably given you a 5 to 10 minute heads up they're coming, or the farmer that's walking in on his clearly broken ankle who says, oh, by the way, I got some chest pain on the way up from the car. And so we like to seem to close off the tied in a little bow, but we let in Pandora's box. And then the next part of this whole thing is, well, if we're going on diversion, we've done everything we can, we've done everything with the system, and this is the only chance we got left. And I would again question if that's really true. Sure, I'm sure they've gone down the nursing list to see who wants to come in for overtime, but have we really moved administrative staff into the clinical settings? Have we really called in our surge plan? Have we really done kind of these things? And most importantly, have we canceled all those elective surgeries that are on the books? You know, every surge plan for every hospital since the beginning of time for flu season has to do with we're going to cancel our elective surgeries. It literally took a pandemic for us to do that. And granted, COVID was bad, and wherever you were and whenever you were, it could be really bad. It was bad in our place, but we always got beds. The beds showed up pretty easily because we didn't have the hospital 80% pre-booked. So again, I don't think that's something that actually is true. The last one, and probably the one to some extent up for debate, that diversion is safer for the patients than an overcrowded ER. And in this case, whenever you have something like this, it's always important to go to the literature. And when you look at the literature on this subject, you're not going to get a whole lot of support either way. There's some studies that have been done over the last 20 plus years. There's a handful that say it's kind of good. You've got, you know, this idea that maybe your EMS resources are a little better utilized. This one out of California, they did sort of like a centralized balanced load model where they said that it seemed to make things a little bit better at the macro level. But then I would also take a look at the micro level at your patients. Every hospital's got a Mrs. Jones. Mrs. Jones has a myriad of horrible sounding complaints and hasn't had a normal lab value since the Clinton administration. But we know her pretty well, and when she rolls in, if she looks okay, we can turn around and get her out in a couple hours. She gets diverted to the hospital down the street that doesn't have access to our medical records. Maybe they do, but it doesn't really matter. She's going to get admitted. She's going to get a bunch of stuff done. She may have an iatrogenic outcome because of that. And oh, by the way, she took up one of their beds, which backed up their ER, which put their ER in diversion and sent us their patients. Now, the bad studies that say it's bad, if I thought these were amazing studies, I'd have them in really bold print in my very first slides. There is some studies that look at mortality outcomes with STEMI patients on systems that are on diversion. Again, to be honest, it's kind of a data dredging association causation question, so I don't think it's that strong of evidence. And there's some studies there's a study out more recently that looked at when the public hospital went on diversion, all the surrounding private hospitals were more likely to go on diversion, trying to avoid, to be honest, those safety net patients, which of course does harm to our patients as they get further and further away of the facilities they probably need to go to. But most of the literature kind of comes down on the middle of, it kind of doesn't do much, it kind of doesn't change much. Or the more recent stuff is like, yeah, we got rid of it and the world didn't end. This is one of these is an abstract from more recently out of San Diego. This Visigraph is a facility I won't mention that I might have intimate knowledge of that was a before after. All the little boxes are when the hours of the day we were on diversion because of an inpatient challenge issue. And as you can see, just looking at it, there's not a lot of difference in anything else. So when you run the numbers, there's not a lot of difference. So when I finally was able to show this to the CMO, the insanity stopped for at least a while. And then this one I'm really excited about. These guys were able to let me use this slide. They're still working up the data right now, but they're showing basically in the Twin Cities area. The only thing that changed randomly over time was that yellow line is the 6 a.m. boarding level. So that obviously went up, but their offload of ESI2s didn't change. Their volume and stuff didn't change. Nothing changed. They told me there's maybe some data to suggest actually things got better, but they're still waiting to run all the numbers for that. So when you look at this, it's like, well, obviously, why do we still have diversion? And this is kind of how I feel sometimes because of this, because we still do it in my shop, and there's still other places that do it. However, a lot of places have gotten rid of it. Most famously, 2009, Massachusetts just stopped it completely. The world didn't fall apart. Over the years, lots of different cities have done away with it. Back in my days when I used to be in Buffalo, we got rid of it. You can kind of pick your skyline there. Here in Austin, they don't have it. St. Louis, some places out west, Cincinnati, Columbus, Ohio, those kind of places. And there's others. These are just the ones I know of off the top of my head. And so basically, we got rid of diversion. There's no such thing as diversion. You're either open or you're closed. And if you're closed, it's because of some sort of disaster or something. A lot of the systems start using some sort of resource using like EM docs or NEDocs, or EM resources to do some sort of saturation score. So basically, hey, hospital X is on double red purple today. They're really super busy. And what this does do is allow the medics and the patients to have a little more informed knowledge of, hey, the place you want to go to is pretty busy. Maybe if you don't mind, you could go somewhere else. Or if you really want to go there, just be prepared to wait for a while. Because of that. A couple of the systems, I like this part, being the EMS guy, looked directly at the EMS traffic through like First Watch and some of the programs we have. And essentially, we don't care what the waiting room looks like. If our EMS units are backed up, then we're going to try to balance load when appropriate. Or if we're moving patients in and out, that's great. Again, your waiting room might be empty or really, really full. And then ultimately, every one of these scenarios, yeah, if there's a disaster, it's a code gray, certainly we're not going to try to bring you patients. So when it's all said and done, I don't want this to be, this is not the expectation. There are reasons that an ER should go on diversion. I affectionately refer to them as the 4 Fs. This is not what you say repeatedly when you see this as your waiting room coming in the door. But basically, it's the facility, you're either on fire, you're under fire, you have a facilities problem, or you have a firewall issue. And let's be honest, we all know the meme that all emergency medicine does is order CT scans. But if your CT system's completely down or your PAC system's completely down, that's a legitimate time-sensitive thing that you may want to move patients somewhere else. And then there's the obvious, if there is an actual MCI. Your shooting scenarios, unfortunately, have demonstrated this repeatedly in Vegas and Colorado. People will go to the closest hospital that overwhelms that hospital. But I would like to think at that point the bat signal's gone up and the rest of the system is firing up, right? Okay, so what do you do tomorrow when you're back on shift? I think you need to make sure you're optimizing some of these upcoming things to minimize the issue and really address the overlying problem and not just going patients on diversion. So EMS has a role in this. I do think some sort of system status understanding of capacity is important, and have EMS have some knowledge of whether it's driven by the data from the ERs or if it's even just a subjective, hey, we're really busy today. They'll know kind of where you are on the scale, and then again can direct patients to say, you know, maybe you go to a different hospital today for this relatively straightforward complaint. Now, when I bring this up locally, I got to be honest, I get the whole, well, it's just, you're just changing, that's what we have in diversion. You're just changing words, red versus diversion. And that may be true, but words do matter. And I think it's important that, you know, when somebody's been doing this for a long time like I am, we're like, yeah, that's fine, divert, override, I don't care. But the new crews of the new medics or the misunderstanding that those words do naturally mean different things. It's important to choose what you say. And then there's the obvious, you know, cry wolf scenario. And this has haven't happened to me. I work night shift, I'm on call. I got a call that said so-and-so hospital wants to go on diversion. And I realized something wasn't quite right, and turns out they had an air conditioning failure and were considering evacuating the hospital. Had I been kind of asleep and just woken up for the call, I would have probably just said, yeah, that's fine, go in anyway, divert, override, because they're always just saying they're crying wolf. And so you have to be careful about that. If your EMS system still expects to go direct to a room, that needs to change. Or if your hospital expects that, that's not, the expectations need to be laid. Patients can go to triage, they can go to fast track, they can go to wherever they need to go based on what their needs are. Just because they came by EMS doesn't mean they have to have a room and a bed. The on-scene treatment, the ET3 stuff got started, and it was a pilot project that was designed specifically for Medicare to be able to treat patients on scene, because up until now, EMS only gets paid if you take a patient to a hospital emergency department. So we were in the early phases of implementing this, trying to figure out how to actually bill and go through all the hoops. And then, of course, COVID hit in early 2020, and the world fell apart. And we just started doing all that anyway under emergency orders. And come to find out, it works, and it can shunt certain patients out of the ER and give them the care they need. So as we look to where we're going, even here in Texas, there's a law on the books now that the Medicaid patients can do this across any ambulance service. And the private insurers are starting to follow up, because they can see we'd rather pay a $500 EMS transport bill, even though they didn't get transported, and paying the facility fee and everything else. So we'll see where that goes over time, but I think that's something that will potentially help offload the system a little bit. On the hospital side, I would hope your hospital's doing dynamic staffing at this point, because, you know, we know most arrival curves look something like this. Why are we still insisting on 7A, 7P nursing shifts or physician shifts? It needs to be growing and kind of breathing with the department to have more resources when you're busy, or excuse me, and less when you're not. When this idea of a patient flow coordinator in the ER came up, I thought it was kind of weird at first, but in reality, it not only helps us kind of keep an eye on those patients that are basically ready to go, but maybe we've just lost situational awareness on, but more importantly, they're coordinating all the chaos upstairs and trying to get beds assigned and beds cleaned and all that kind of stuff, which brings up the bigger point that the whole hospital has to approach this as an active process. Hospital discharges, I think, historically have been a passive process. And so making it more of an active process and doing this at all times of the day and really focusing on this will move the patients out of the building, which allows us to move the patients upstairs, which they've shown this 20 years ago in Syracuse. If the patient is stable, the patient can go upstairs to the floor. because when the patient is staring at the nurse in their hallway, that bed is liable to get cleaned a lot quicker than if they're still in our ER, out of sight, out of mind. And I saw this personally a few months ago. My wife had a little post-op infection. We did have to readmit her. Everything was fine, but we got her direct admitted, which in and of itself we thought was pretty impressive. And I took her upstairs because they said, here's your bed. And I said, we don't need transport. So I show up. Sure enough, the room was dirty. And I was like, oh, don't worry. We'll wait. We'll sit right over here out of the way. Room got cleaned really quickly. So it's like, this does work. I've seen it firsthand. So at the end of the day, my point of all this is diversion isn't doing what everybody thinks it's doing. It's just moving, at best, moving deck chairs around, and it's really not the fundamental problem. There are reasons a hospital should go on diversion, important reasons, those ideas of essentially some sort of internal disaster that is, by practical purposes, closing the ER. I do think there is a role for some sort of balance loading or system status understanding so that within reason, EMS can find ways to make the system a little diffuse out when there are those true isolated surges. But if we're lucky, maybe someday we'll get to the point where diversion's over. We don't talk about it anymore. I'm not going to turn your waiting room into this, but we can, have the nice Texas sunset and ride off. All right. Any questions, Dr. Lee? Do you have any questions? Excellent. Great. Yeah. Yeah, unfortunately, you touch the stress surface of the entire healthcare problem. Hospitals make a lot of money on the surface, and had it not, so we're never going to do that again. I mean, if they were able to, there's obviously a lot of federal support and funding when you're going to pain, but hospitals are still struggling hiring for that. So, unfortunately, not really. Even today, if anything, what happens is those easy off surgeries you have to do, surgical centers being built, and these kind of hospitals for all the straightforward patients. And they talk a lot about, hey, we have great outcomes. Hey, we have great outcomes because like patients which means the more complicated ones are the ones that go back to the hospital. So those in-and-out day surgeries last, and really usually last and last. And so unfortunately it doesn't really haven't changed much. It's just a mindset of making the entire hospital more efficient, which unfortunately sometimes there's incentives to do that, but a lot of times. Well, interesting enough, I mentioned we did some good work on the ER, and the hospital's happy with it. We got pretty straight numbers. And I think internally for our processes, it was expanded. I think it helped with wellness, with our education model, and things like that. But what really moved the needle more than us is that they did a lot of stuff upstairs to realign the floors and the discharges to make it around the process, and really looking focusing down on that so that we can patients down more and moving the needle some. It's not, not a perfect solution, but it's moving the needle down so that when they're up there, we can get a patient. So we're optimizing our efficiency. So we could be more efficient if we were kind of shy away or not because it's that. So as they become more efficient, we can be more efficient. At the end of the day, again, it's this idea that it's not the solution to the problem. So why are cities doing that? And I can't say it for sure, but I don't know of any cities that stuff that has done away with this idea of volume initiated diversion and ever gone back. Because once they everybody kind of looks up one day and goes, oh, yeah, we're busy, we're always busy. And that's the thing, is, you know, in some sense, and this is one of the things, just a little bit on that city thing. I don't know, up until relatively recently, and honestly, really kind of mid-slash post-pandemic, we actually had an oversupply of hospital beds. It didn't seem like that on the surface, but we really did. And now the city has grown so fast, because for years what happened is the academic places before, we'd be on the roof all the time, like alluded to, upstairs rooms, they're thinking and counting, but nobody else would be, because the private hospitals were basically told, don't ever go on diversion, it's a market share thing, and all that kind of stuff, because ambulance patients pay. Even though people may not think this, they're usually insured, they're often Medicare, those are patients talked about 15 years ago, the day it came out to kind of realize hospitals suddenly saw and said, oh, wait, we want this practice. And so if anything, if you believed in the model, they were basically suppressing the need to go. So it always looked like it was just one or two. So when I bring this issue up, the regional leaders and stuff, they're like, we're fine, we've got our system, we do this, we go on divert override, and we never have to do this and all this stuff. And now the last couple of years, the floodgates have opened, and I know it's a busy day in the city when my text keeps going off, and I get every single diversion in the city. And it's one of those, I'll see us go on, and I'll be like, there goes that, there goes the other, I'm like, oh yeah, it's a busy day in the city. That doesn't change anything. So it makes people feel good that they're doing something, but they're not doing anything. But they are potentially harming patients, because the more those ambulances are on hold. I will say this, our city is good about not having long wall time. So I think that's coming. We're like, the canary's working its way out of the goal line, but that's coming. They just don't know. So I predict in the next 3 or 4 years, when we're in ridiculously saturation all the time, and we're always on the verge, they'll finally start having these real conversations with like pharmacy. But it'll take time.
Our numbers don't change for our EMS.
No. And
despite the hurting, we still get almost 1,000 EMS runs a month.
Right. Because like I said, in a lot of systems, especially if you're talking about, the classic ones are often the academic data centers that do this all the time. Well, in our system, for example, if they're part of the county health care coverage system, they come to us regardless. If it's a trauma patient, they come to us regardless. If it's so there's so many carve-outs that even if you could tease off, even if you like really did shut the door effectively, you're still getting a huge amount. And then other hospitals are working it the same way. So. Well, thank you so much. Thanks. I can give it again somewhere. Nobody will know.